Hi, my name is Ray Comenzo. This is the third in a series of videos that we're making about plasma cell diseases. Today is December 14th, 2015. We've had a very exciting period in the universe of plasma cell diseases because new drugs have been approved, ixazomib, elotuzumab, and daratumumab. I'll be talking about those new drugs in the fourth video that we make. This video is devoted, however, to stem cell transplantation for multiple myeloma. We divide new myeloma patients into the transplant ineligible and the transplant eligible. As a rule, patients under the age of 70 are considered transplant eligible. However, there are patients in their 70s who have the biologic equivalent of a more youthful performance status and organ reserve, and therefore patients up to the age of 76 to 78 are sometimes considered transplant eligible depending on their functional status. Certainly, frail older patients are patients for whom standard therapy is very important and very useful, but they are not considered transplant eligible. Let's dig a little deeper into this concept of eligibility for stem cell transplant, when stem cell transplant might be done, the status of the patient at the time of stem cell transplant, how it's done, and what the outcomes have been. It's very important to make sure that major organ systems such as the heart, the lungs, and the liver are functioning at a good level prior to stem cell transplant, because transplant is an ordeal that challenges the heart with fluid shifts, the lungs with the risk of infection, and the liver as well with metabolizing medications that are used to support patients during transplant. In multiple myeloma, the forms of stem cell transplant that are employed are both autologous stem cells from the patient, him or herself, or allogeneic stem cells from a donor, usually a sibling, brother or sister. I'm going to be talking mostly about stem cells from the patient, autologous transplant, because that's the most common form of transplant that's offered for patients with multiple myeloma. The tests that we use to screen patients, and in many instances, insurance companies require these tests as a minimum and may require additional tests, include tests for the heart, such as an echocardiogram, to ensure that the heart is able to pump in the normal range. Tests for the lungs, including what is called a diffusion capacity, to ensure that the lungs are functioning in a normal range and to minimize the risk of infections due to lung disease, and standard blood tests for the liver. In addition, we do transfusion transmissible disease testing for several reasons. One is to make sure that the stem cells, when they're put in liquid nitrogen for cryopreservation, are not at risk of contaminating other patients' stem cells in the liquid nitrogen freezer. And two, to determine if patients have hepatitis viral infection that might have been undiagnosed. The presence of chronic active hepatitis or liver damage such as cirrhosis can be an impediment to stem cell transplant for multiple myeloma, because of the fact that the medications we use in many instances are metabolized by the liver, and an already damaged liver may become even more damaged as the result of the ordeal of stem cell transplant. The first step in the process, after insurance approval and eligibility screening has been performed, is to make sure that the patient's disease is appropriate for stem cell transplant. And we're talking about myeloma at this point. So in many, many cases, studies for response to initial therapy will be performed, and patients whose myeloma is chemoresponsive early in the course of therapy are patients for whom stem cell transplant is likely to provide a benefit. In the modern era, there are two tracks that patients can follow. One track is to begin therapy, and after, say, 4 or 5 cycles of therapy, when their disease is under control, to have their stem cells banked for later use. The other track is to have stem cells collected and used within the first year of therapy. The data that we have as of this point in time suggests that early transplant is a benefit to patients who are transplant eligible. The most recent study done in France has shown that patients who have transplants performed after induction therapy have a longer period of progression-free disease than patients who continue on chemotherapy and maintenance therapy and often relapse sooner than they would if they'd had a transplant. However, as with many, many myeloma studies, the data are clear. There's no difference in overall survival between those two options. It's just a matter of how long the disease is under control securely. All of that having been said as background, let's assume that you're a newly diagnosed patient who's been through induction therapy. You've had a good response to initial therapy, a very good partial response, or even a complete response. Your heart, lungs, and liver are fine. Your kidneys are fine. And the option of high-dose therapy has been offered to you. And you decide to undergo stem cell transplant with high-dose Melphalan. The first step is collecting your cells. We do collect stem cells after some stimulation, either a combination of a medication called cyclophosphamide and another medicine called Neupogen or GCSF, or with GCSF alone, often combined as the collections begin with a drug called Plerixafor or Mezobel. All of these techniques are designed to push your stem cells from your marrow, where they live, into the blood, where they can be collected easily by a process called leukapheresis. Leuka means white blood cell, apheresis means a taking away from the blood. And leukapheresis is performed by a device called an apheresis machine, which is like a large washing machine. It is very safe to have stem cells collected for, say, 2 or 3 days, usually from either a large bore catheter that's placed under the clavicle, under the chest bone, the collarbone, or by IVs that are in both arms. It's a very safe procedure. After the cells are collected each day, they're carefully evaluated for the number of stem cells, and they're cryopreserved in liquid nitrogen, where they can last for many, many years. We try to collect enough cells for 2 to 3 transplants at the time of mobilization and collection, because we know that transplant and other cell therapy techniques may be important for patients in the future. So now you've had your stem cells collected. You're awaiting admission to hospital for transplant. In some centers, transplant is performed as an outpatient form of therapy. The process now goes to delivery of chemotherapy, which is done initially over a day or two, and then often after a day of rest, stem cells are given back to the patient. So the chemotherapy, which is more often than not high-dose Melphalan, is a chemotherapy that is very effective against the remaining myeloma cells in the bone marrow, but also eliminates the good cells in the bone marrow. And therefore, the seeds of a new bone marrow in the form of stem cells need to be planted. After stem cell infusion, patients go through a period of 5 or 6 days of wondering why they're in the hospital and wondering if anything's going to happen. In that period, they feel fine. Perhaps at worst a little bit of nausea, which is easily managed with medicines. Patients are eating and drinking normally. And then after about 6 days, the blood counts drop, as we expect them to. And in that period, from about day 6 after the stem cells are given until about day 11 or 12 after the stem cells are given, patients are at risk for infections and for bleeding. So in that interval, patients receive IV antibiotics if they develop a fever, as well as blood products, red cells and platelets by transfusion, to minimize the risk of bleeding or the side effect of anemia. Throughout this process, patients are on preventive medicines, oral antibiotics that they would have started the day after the stem cells were infused. Patients are given more growth factor, Neupogen or pegfilgrastim, in an attempt to stimulate the seeds to grow a little quicker. And also patients are given IV fluids as needed over the course of the first couple of weeks in the hospital. By about day 15, most patients have begun to recover their white blood cells. And certainly by day 21 or 22, patients are, in many instances, ready to be discharged from the hospital. Things that can keep the patients in the hospital, though, are number one, infection. And about 1 in 25 patients develops a bloodstream infection that requires IV antibiotics for several weeks. The last few days of the IV antibiotic therapy can be administered as an outpatient, so patients don't necessarily have to stay in the hospital for that. Occasionally, patients, perhaps 1 in 30 or 1 in 35 patients, develops chemotherapy-induced sluggish gut, and that means that patients get a little nauseated when they eat or drink anything, and therefore occasionally patients need to be fed by vein for a period of time. The safety of high-dose Melphalan and stem cell transplant for myeloma patients cannot be overemphasized. The rate of death associated with transplant in the first 100 days is less than 1% at almost all major centers performing stem cell transplant for myeloma. It's an extraordinarily safe procedure. The critical feature of stem cell transplant, however, that is of greatest benefit is that in all of the major studies in which patients have been randomized, like with a flip of a coin, to receive stem cell transplant or to go on to maintenance of some form of standard chemotherapy, and these studies go back almost 20 years now, patients who've undergone stem cell transplant have had better progression-free and, in numerous studies, better overall survival. We believe that stem cell transplant can add 1 to 2 additional years of survival even in this modern era when patients diagnosed in 2015 with standard risk myeloma can be expected to live 15 years from diagnosis or more. The critical questions to ask your doctor when stem cell transplant is being discussed with you include simple things like, do I have to take a short-term disability from work? The answer is usually yes. Can I delay the stem cell transplant until my retirement? This is an issue for policemen, firemen, and teachers who may be within 1 or 2 years of retirement. And the answer is yes, but you'll need to continue on some form of therapy as you approach that point in time when stem cell transplant is appropriate for you. The other things to keep in mind are, how do you do stem cell transplant at this hospital, and what are your results with patients? The vast majority of patients who go into stem cell transplant with very good partial or complete responses do extremely well for several years after transplant. And with modern consolidation and maintenance therapies after transplant, most patients can go 4 or 5 years before there's any evidence of progression of the myeloma. As you can tell from what I've said, there are differences of opinion regarding stem cell transplant for myeloma. I believe that transplant provides a benefit and that the data are very clear for transplant-eligible patients, that certainly collection of stem cells early in the course of induction therapy and, in my opinion, early stem cell transplant provide a benefit. I do not view the procedure as a high-risk procedure. I do not view it as a huge ordeal. The convalescence after transplant usually takes about 2 to 3 months, and most patients are quite well by 4 to 5 months post-transplant. In older patients, it's worth discussing in detail what the side effects might be and what the doses of medications need to be changed to. That applies also to patients who are on dialysis, who are candidates for stem cell transplant at a reduced dose of Melphalan. In a later tape, I will discuss allogeneic transplant for Melphalan, with Melphalan for myeloma. But in this tape, I really wanted to emphasize the role of autologous transplant in multiple myeloma. The next video will be on the new agents that we have, an overview of the waterfront of new treatments for myeloma. And then we're going to go on to discuss amyloidosis beginning in, I believe it will be tape 5. So tapes 5 through 7 will be very relevant to patients with light chain amyloidosis. Thank you for listening.